I wish I can go on a mountaintop and decry something and then have so many people listening, actively or not. But um, there's a lot going on with the statement so short, so succinct, and so powerful. Um, the question is, where does the action actually go? Um, you know, I will give you the short answer. Don't worry. But when you think about it, it dives deeper. This headline, this statement hopefully makes a lot of people stop and think, how do we organize our healthcare system overall and access to medications? So, this idea of, oh, everything's OTC unless, and somehow that gets lost in the shuffle is the unless. Like you said, oh, unless it's unsafe. I have significant questions with that terminology. I'm sure other pharmacists do as well too, well, unless it's unsafe. Well, if it's unsafe, why would it even be a prescription product? I mean, you know, right out of the gate there. So, in an objective pharmacological sense, hard to agree with that concept. Or yeah, to a point, well, wouldn't it be OTC, but then would it still be prescription even? Um, the other side, of course, if something could be misused, abused, diverted, you name it, there's obviously concerns with that. Um, we have other OTCs currently where that comes into play, but that doesn't lay the land for the future either, though. But it really begs that question of, what's our categories? How do we go about the organization and regulation and eventually enforcement of medications in our country or substances overall? So, you know, kind of easy to agree with if it, that part of it, just objectively speaking. The other thing that was mentioned too, in his statement was that, oh, if something requires monitoring, and I actually said that statement of like rewording it a little bit to say like, okay, well, if something requires monitoring, it's almost like you could whittle it down to that's the definition of a prescription medication. So, it's a lot of pomp and stance going on there. That mountain I talked about, smoke from the mountain of, well, if something's unsafe, I mean, where should it be anyway? If something requires monitoring or could be abused, it's almost like we're talking about the core definition of prescription medications, if not controlled substances, of course. So, didn't give the yes or no for you there, but there's dissecting it, there's different parts to consider there. And it's really important to do that, of course. That component doesn't make our lives easier as pharmacists, of course, because it's more information to go over that gets very convoluted. When someone's copay is $13.57, I mean, seriously, how do we explain that? There's components that go into it, but and then in a larger picture, like you're saying, well, you know, coverage for prescription products, if something's not a prescription, then how's it get covered in a prescription drug plan? We have precedent for that, even in quite volatile topics. Naloxone, opioid mu antagonist, the concept of some of the naloxone products being OTC. There was, certainly concern across the board in healthcare for, well, will there be coverage then if it's available over the counter? It comes down to the individual insurance plan, not even the company as a whole, but the plans, the multiple plans for each company to make those formulary decisions. Um, but at the same time, it's not like they're not enabled to make that decision when then it's a prescription product either, hence formularies. So it just opens up another door of ambiguity. At the same time, though, with potential OTC to prescription, it does enable you think about all the efforts for collaborative practice or prescribing for pharmacists. We see many examples of that anymore. Well, if something's OTC, it's not that, but it's almost inherent to that. So access, part of it can increase because, well, if it's OTC, gas stations got it, grocery stores got it. It opens up that part, but access also includes cost to the core of your question. And that's going to differ product to product. And that's going to be very confusing for patients and, quite frankly, healthcare professionals alike. I think you're trying to get me tachycardic here. Um, you know, that word that I was using earlier that we talked about, access, it's incredibly important for people, right? Can there be too much access? Perhaps, but That balance of safety and efficacy is incredibly important. A lot of folks, even some pharmacists have said, like, oh, what if some of these grandfathered products from decades past, I'll say, what if they came out today? Would they be OTC? It's a kind of a legit question. Again, it provokes thought into how we organize things in our healthcare system across the planet too, of course. But um, you know, the OTC idea is that people perceive that as safer because they don't have to go through the hoops to get to it. All medication has its baggage, though. It's just inherent. Even current over the counter medications come with baggage. Safety concerns, interactions, side effects, you name it. Um, that's inherent along the way. But there's a delicate balance between the access and those safety parameters along the way. There's just those times in the core of any healthcare system where, requiring, mandating, or making it an innately part of the system to have a healthcare professional alongside a patient, a customer in certain stores, not even our pharmacies, is for the benefit of that person. It's almost like we're talking about a parenting concept here. Like, I want you to have access, but I don't want negative things to potentially happen. Will it happen for everyone? No, but it could. And that balance is very delicate. There's been even examples, I believe, from other countries, but we've considered it even our country of like, well, should we add a different level, like in simple words like behind the counter, where you would eliminate the access in the various stores, dollar whatever stores, gas stations, grocery stores, like we mentioned earlier, and limit to a pharmacy where they would be required to talk with someone. We got to watch ourselves with that, though. I mean, as healthcare professionals, one of the last times I was a patient in pain, mind you, when I went to the pharmacy, I needed you to sign here. You think you made me tachycardic 3 minutes ago? Good golly! Um, when the Spider-Man thing. Oh, our oldest son would love this one. Power, responsibility comes into play as well too. We've got to practice at the top of our license to even consider those types of things as well. And that's really where it hits the patient care in the big picture. It's a phenomenal conversation. We got to avoid in healthcare, particularly pharmacy, making it circular. We want action-oriented conversations. Folks are going to APHA or ASHP or wherever, action oriented on there. So, making a plan to say, well, what are the benefits? What are the potential shortcomings of having an additional classification of medications? And because, access again, well, if a pharmacy is not open, then how do you get that as well? We're talking 2 a.m. or whatever. There's certainly 24-hour stores, but not everywhere and not all of them. Um, potential shortcomings. But in the big picture, it makes it where then, you get some counseling, you get some advice along the way, or at least the opportunity thereof, and including that access. Perhaps like that, what you brought up earlier with the payment structures as far as insurance coverage and all that. Maybe there could be something involved with that as well too. That's all kinds of brainstorming thoughts right there on all sides there. But the general idea is that would add this behind the counter status or pharmacist only, or maybe somebody else could come up with a cooler term. But I'm not concentrating on that. It's just the concept that it adds another layer of access where, I mean, let's be real. When's the last time any of us, anybody listening, went through our healthcare system and just was delighted? I'm talking like Disney delighted, okay? It does happen, by the way, and quite frankly, I really hope it's a whole bunch of my patients. But anyways, um, it's just different, okay? And that's, but the access needs to be there as well too. There's a lot of hoops. There's a lot of time. My love language is time. I don't like to waste it along the way. And I know I'm not alone out there. A lot of other people like gifts or this or that or words and affirmations and all that stuff. But like, no matter what, our time is very valuable. And we have to look at ways to enable that. I actually had, this is going to be a little bit off the wall, but a couple months ago, um, so I'm aging, let's say balding, guy from West Virginia. Okay. So the algorithms all of a sudden a couple months ago, this is where you go to the edge of your seat, folks, started sending some medications my way in the algorithms of social media as far as ads. Buck a pill, it'll be on your doorstep tomorrow, if not the day after. Okay. That's access. All right. Is there safety concerns? Oh my gosh, yes. So I let my wife know, hey, I'm going to click the button and learn more. And then, of course, that could get a little bit dicey along the way. You've got the hair stuff, the ED things, you name it, the little blue pills and all that stuff. And I clicked it and I got 15 more. All of a sudden, that was my entire feed. And I screenshot it and I put it on LinkedIn and was like, think about this. Like, this is actually something we could learn from. Yes, in the safety side of things. But why is it that these recreational things I can get cheap and quick compared to being held hostage for a refill for a seasonal allergy nose spray? I've lived that. Perhaps I'm going a little extreme in saying hostage, but you know what? It's like, come on, folks. Um, it brings up a whole nother thing of, again, that access overall. And, that's that statement from Mr. Macri. It's hopefully there's intentions there of provoking these thoughts. Okay. There's a sensationalization to it as well. Everybody loves a little bit of sunshine and limelight and all that stuff, right? We all get our, what's it, 15 seconds or whatever, and some get 15 years. Um, that's inherent. That's what's happening there, of course. It provokes these conversations like we're having here today, though, to get that thought going as well. That's the glass half full approach, perhaps. Ooh, that's another you're on a roll today. It that's just like, how would you fix everything on a random morning or afternoon? Um, Good golly. So, I don't wanna be a hypocrite because, we're all given 24 hours in a day. What we do with our time is our choice and, most of the time. But, we gotta be active within our profession. So, not just being a member of organizations, but active, actually being there. Does everybody have to do every conference every year? No. Do some people? Yes. But um, because that's where voices are heard and propelled, and the connections are made, not just in a lobbying sense or any political action things, but you know, um, beyond that, though, to get the ball rolling and make sure that those relationships are there to keep companies, to keep legislators all together along the way. I mean, essentially, what you're inherent in what you're asking there is who's driving the bus? How do we, balance business and, the finance meets clinical, right? Clinical, the corner of clinical and cash. These companies are corporations. They have stockholders. That's technically who's in charge, right? Maybe not the guy or gal with one share, but there's boards, there's this, there's that. There's a lot that goes into that overall. That being said, on the other side of the coin, trying to be fair, of course, is there's also good intentions out there as well, too. The better that something works and there's access and this and that, safety, efficacy, the more that stockholders would be happy as well, too. So there's a balance there, but it's really just keeping people informed, people in influential positions, whether it's in corporations, legislators, you name it. And it really starts in just making sure that oh, what's the Hamilton thing? Making sure you're in the room where it happens. Most of us aren't gonna be in a board, CEOs, C-suites, all that kinda stuff. But, we could get ourselves in the rooms where those folks get the right information. And it's all about getting that right information out there, preventing the misinformation and the spread of everything else. Sensationalization and, strategic as well too. It works. Literally, here we are talking about it, and we're obviously not alone. Other people have already been talking about it along the way. To think that we're gonna overhaul an entire system that's taken, a century to create within, I think it's the parameter was about 2 years, if not 3. That's, in schools of pharmacy in the first year, P1 year, we go over a lot of soft skills. We go over a lot of stuff that's not even medications yet. One of those things is SMART goals. measurable, attainable, all that kind of, and timely is that illustrious T at the end there for the acronym. Um, that would not be a SMART goal. And that's, that question, I appreciate how you word things to try and avoid the politics, of course, but it's inevitable within it all. But it's objectively speaking, if you dissect it into, is this a SMART goal? That's just not a SMART goal. Um, the the subjective side would be like, well, if we get rid of the little periods and just say the word smart with it, that's an opinion. I like to avoid that on a hot mic, because we're all entitled to our opinions. It's not like we have to influence others. But as far as that being a smart, the acronym goal and timely and achievable based on the past of our country, that just doesn't seem in line. But it does plant a seed to keep these conversations going. It doesn't start them. We've already had them, but it keeps them going for the potential changes and analysis of access for patients. We've got to make it easier to get healthcare for the each patient along the way. And that's really what it all comes down to in the big picture.